Thank you very much, Dr. Hilya Ansari. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. Thank you very much, Professor Masud Sitin, for inviting us to this symposium. I'm going to start by talking a little bit about Malaysia. This is my outline, the burden of disorders, the mental health principles, the reform that we had in Malaysia, and what's the service plan and the district health systems. As like in Malaysia, mental health and mental resources are not regarded as the same. There's low priority for mental health and mental disorders. We have to play politics with the bureaucrats in the Ministry of Health. I work in the Ministry of Health. My three colleagues work in the universities. We run parallel systems. We don't mix together. They train, we do the service. I will show you the large burden of disease and huge treatment gap in Malaysia as well. Availability of effective treatment, but poor accessibility to most people. So in Malaysia, the burden of disease about mental disorders contribute almost 7% of the burden of disease. It's only second to cardiovascular disease. And in women, 35 to 45 years old, it is number one. The prevalence of mental illness in two 10-year surveys was about 10% and 11%. These are some health facts. I just learned that Turkey is 2 times the size of Malaysia. We are 300 kilometers. Turkey is about 780,000 square kilometers. Our population as of end of 2012 was 29.6 million people. Turkey, I learned, is about 76 million people. So you are double than us. Double, yeah, roughly. And those are our basic characteristics. Right. Most of our patients are treated in public hospitals. Public means the government pays for everything. We have two systems. No insurance in Malaysia. One is private, where people pay out of pocket mainly, and the other is public, where they don't pay much. And 90% are treated in public hospitals. This is our mental patients. There are 43 general hospitals and 4 mental hospitals. I work in one in the south of Malaysia. I don't know where the map is, couldn't show you the map. One is in the central region, 2,400 beds. I work in the new one, 1,200 beds. There are 2 more big ones, 300 and 250. There are about, up to now, 280 qualified psychiatrists, and some aspects of services are available in primary health centers. These are government-run health centers where they give medication follow-up. They do mental health promotion. In about selected centers, 27 of them, they do psychosocial rehabilitation. And there is a mental health unit in the public health division which coordinates all this. This is the burden of disease. What I would like to show you is that among the DALIs, ischemic heart disease, cerebral vascular accidents, and mental illness are the top DALIs. Right. We had a national registry for schizophrenia, and there were about 2,500 new cases every year. This is consistent. So that's the number of new cases that we have. We can't really calculate the prevalence because the incidence, because not all centers report this. What is interesting is that most of the contact are as inpatients, and almost everybody gets monotherapy treatment. This is the new surveillance that we did. We found out that major depression is 1.9%. So there are about 500,000 people in Malaysia with depression. Generalized anxiety is about 1.7%, another 500,000 people with generalized anxiety. Our alcohol problem is low, but 320,000 people with alcohol problems. So because of this, there's a huge treatment gap. So at any one time, 12% of population may have any mental disorders, but only 20% receive any treatment. And those who receive treatment, 3/4 will stop treatment, And another 1/5 will report that they do not have any response to treatment. This is principle for community mental health services. I'm not going to bore you with these details. We just had mental health policy from 1998, which was revised last year. I did a study on the mental health policy. There was poor implementation. There were no timelines. But there's a good vision there. We want to reduce stigma, want to promote mental health. We want to prevent mental health problems, ensure holistic services. I'm sure these are just good words every mental health policy will have. And these are the elements of the policy: good governance, acceptance, comprehensive, accessible, and so on. But mental health services are widely underfunded. And Malaysia do not have a separate budget for mental health. And our budget for mental health is about 3%. And for Malaysia, our access to psychiatrists is much lower. I'll show you the access there. We are about 0.7, 0.8 psychiatrists per 100,000 population. Very low numbers of nurses. 0.1 clinical psychologists. I've never worked with a clinical psychologist all my psychiatric life, except from last week, because we had one clinical psychologist who reported duty to me last week. So I'm beginning to learn to live and work with the clinical psychologist. I have to adjust to her thinking. We have low numbers of social workers. So we are somewhere in between lower middle income. Slightly higher than lower middle income, but definitely not upper middle in terms of services. And this is the total number of beds or services that we have. 5,500 beds in total, but almost all of them in these 4 big hospitals. Let me show you in this WHO pyramid. So 4 mental hospitals up there, which occupies almost 90% of the resources for mental health. We've got 28 to 45, depending on general hospital units, fairly comprehensive, but not many beds, about 900 beds in total. We are starting to have community mental health centers, not enough, but we do have community mental health teams that functions from the general hospital units, which will be touched upon by my other speaker. We have about 700 primary healthcare people working, offering basic services. This is the old hospital that I was working before. 2 years ago, we moved to this new building. This is the community mental health team that I've mentioned. I'm just going to pass it by. And I started the first family support group training. It's going on very strong in most major towns. This is an example of families meeting, an example of them meeting together, and media coverage about family support groups. This is one of my favorite programs. Right, among the principles of the community mental health services that we have are this. And deinstitutionalization is one of those that we wanted to embark upon, but nothing happened. And these are the usual problems. Mental health, the bottom half, low priority for mental health. Although we say we treat depression, anxiety, and stress as a general medical condition, but it doesn't get happen. And we pay attention on how care is to be delivered, and we already have this integration in general health as part of the vision and mental health policy. So what we did was, in the year 2011, we embarked on this Minda Sihat. Minda Sihat is a Malaysian term called Healthy Mind. This is a project where we wanted to target depression, anxiety, to be treated by non-psychiatric staff at health centers. So it's part of the Healthy Life campaign to improve health by managing stress. So we introduced some form of screening. The screening is not to be a academic screening, but it's more of a gimmick or a talking point for the general population. And after the screening, when someone is reported to have mental health problems, we just say you are stressed or anxious, your anxiety is high, your stress is high, or depression is high. Then they have a face-to-face session with a nurse. And what the nurse do is 2 things: provide them information on depression and anxiety and stress, and help with problem solving. And the nurse will help with relaxation, using either Western methods of relaxation, deep breathing and so on, or get them to do massage, traditional massage or acupuncture. And after 2 sessions, the persons are assessed. If they still have high scores on this screening item, they are then seen by the doctor for further evaluation. So this is the program where we wanted to deliver psychosocial interventions in centers outside psychiatric centers by people who are non-psychiatric trained, using simple cognitive-based, we don't want to call it cognitive-based, we just call it interventions, population-based interventions. Right, and this is the aims, and what we do, this is a pilot project involving 10 primary health centers. We screen almost 6,000 patients, out of which 2/3 had high scores for depression, anxiety and stress, and there were 60% females. A lot were Malays. There are 3 big racial groups in Malaysia: Malays, Chinese and Indians. Not surprising that Malays were high, because Malays are the ones who attend these primary healthcare centers. The Chinese and Indians will attend private GPs anyway. So this is the rate of those who are high stressed, highly anxious and highly depressed. They are not clinical, by the way. And the aim is not to pick up clinical, but to talk to them about anxiety, depression and stress. So after 2 sessions, 3/4 improved. That means the scores went down. Only 1% were needed to be referred to a psychiatrist. About 1 in 6 saw a counselor, and 10% was seen by a family medicine specialist. So 1 out of 10 saw a specialist, either a family medicine specialist or a psychiatrist. 1 in 6 saw a counselor. 3/4 improved after talking to the nurses. Right. So there were some issues here. From those numbers, 3/4, you notice 64% had high scores, meaning to say that 3,800 potential people with problems with stress and depression. So, but the first level intervention worked for about 2,500 people. So the issue of sustainability will arise. So we need to train more people, not just nurses, and we need to train people at the primary care level. And this brings me to mind the similar program done by people in Uganda, in Pakistan and Goa, where you either train non-medical staff, village midwives in Uganda, for example, midwives, professional clinic midwives, and general volunteers in Goa. So this is something that I'm looking at now. So what we have shown is that at the primary care level, with nurses who are non-psychiatric trained, they can deliver such care interventions effectively. And with high numbers, about 1 million of people with anxiety and depression that need to be handled, you need to have another strategy. We cannot be training more counselors. We'll never achieve the numbers. We can forget clinical psychologists. We will not get those numbers. So you need to think out of the box to train people outside the health system. And the care is low tech, really. As we've shown you that if we just 2 sessions, first session talking about problem solving, second session about reinforcing those, and it will help them to reduce such levels. So the challenge now will be to unpack, simplify, unpack and help deliver these psychosocial packages so that other non-health and non-mental health staff can deliver this in everyday, easily accessible settings. Thank you very much.